Okay, so we're going to talk next about induction or augmentation of labor. First, you need to know what those mean. Induction is starting labor when there wasn't previously labor, so starting from scratch. Augmentation are interventions that are done to stimulate contractions after labor has begun. So it's already started. We're going to try to speed it up or make it stronger. So what are the medical indications for this? If continuing the pregnancy would be dangerous to the mother or the fetus, then this might be done. Okay. It also has to, in order for an induction to be done, it should be a case where labor is not contraindicated. Elective inductions are often done for various reasons. They can be for social reasons for the family, maybe maybe the father of the baby is going to be deployed, or they prefer a specific birth date, things like that. Also, they may be done to make the process of labor more convenient for providers. There are providers who try to induce most of their patients' labors on certain days of the week, which makes their work schedule more predictable. There's controversy about elective induction because it is more likely to result in C-section or in an unsuccessful vaginal birth, but also there is a risk of iatrogenic prematurity. The baby's delivered and it's actually not quite ready to live on the outside. So there are some risks with induction, and there's some controversy about elective induction. At one time, elective inductions were very common. From pretty much the time that we decided the patient was full term, which is 37 weeks, they were open for induction. So a lot of providers were inducing most of their patients at 37 or 38 weeks. So what was happening is a lot of those babies at 37, 38 weeks, they're delivered, and then they have some respiratory difficulties or some difficulty with that transition because they were not quite ready. It doesn't change mortality significantly, but there were a lot of babies being delivered at 37 weeks or even 38 weeks, and then having to go to a NICU somewhere for observation and care for a few days. So that's besides the bonding issues, besides the stress on the family, the anxiety about a sick child, being separated from a newborn, all of those are issues, but also it's expensive. And Medicaid decided that they were not going to pay for any elective inductions before 39 weeks. So that doesn't mean medically needed inductions aren't paid for. But if the induction is just being done to get the baby delivered, then 39 weeks, it can't be any earlier than 39 weeks. And that really decreased the numbers of babies who were being sent to NICUs after an induction. So what are the risks of induction? Iatrogenic prematurity. They're not quite as far along as we thought, or maybe just that fetus isn't quite as ready at 37 weeks as another one might be. So there's a risk of iatrogenic prematurity. There's also an increased risk of cesarean, because if the patient is not actually going into labor spontaneously, that's an indicator that their body may not labor effectively. And so someone who's induced may actually has a greater risk of having a C-section. There are a lot of different methods that are used for induction. There are some natural or alternative methods that are used to encourage the onset of labor. You've heard of some of them you may not have heard of, but there are some. Having intercourse actually has a couple of effects. The maternal sexual response can cause release of oxytocin, which causes contractions, but also semen contains prostaglandins, which can also trigger contractions. So intercourse, yes, actually can trigger the onset of labor if the patient is ready to labor. Walking, this tends to be more helpful if they're already having some contractions and then they walk to try to get them more regular. Breast or nipple stimulation, for the same reason as intercourse, it causes release of oxytocin. Acupuncture has been used. I don't know if there's a lot of research to back that up. The major risk of acupuncture is either it doesn't work or infection. So, and that infection risk is low because it's pretty superficial. There are some herbs that are sometimes used to try to induce labor. The safety of those is undetermined, but if an herb causes contractions, there's a risk that it can cause too many contractions, too close together, or too strong, and that can cause complications. So be aware that people may use those things. You also may have heard of castor oil. Castor oil will cause diarrhea because it's a laxative. It does not typically cause diarrhea in the fetus because it's a locally acting laxative. But if a patient is ready to labor, then all of that intestinal activity sometimes triggers some prostaglandin and triggers some contractions. So there are patients who will try to use castor oil for induction. Make sure if they're doing that they're hydrated. We don't recommend it, but if they do it, hydration is going to be the issue. So moving on to medical methods for doing this, sometimes one of the first things we want to do is assess cervical ripeness. And they actually assess cervical ripeness using something called the Bishop. The Bishop score is a method for scoring cervical ripeness. If the cervix is ripe, that means it's softened and it's preparing for labor. And so the Bishop score is a method of predicting how likely that patient is to respond to induction with a successful vaginal delivery. So they look at the position of the cervix. Is it really, really posterior in the back, or has it moved closer toward the front? The consistency of the cervix, is it firm? Is it soft, or is it kind of in the middle? Is it effaced at all? Is it dilated at all? And the station of the fetus. So the Bishop score is calculated, and the higher the Bishop score, the more likely that patient, that induction will be successful. So that's one of the first things that's done, is try to determine how ripe is that cervix. There are some methods of ripening the cervix. So if a patient and their provider are planning an induction, and that could be for medical or social reasons, they might try some things to ripen the cervix first. So one of the most common methods is using prostaglandins, and there are different ways for those prostaglandins to be applied. Dynaprostone is one of those prostaglandins, and the trade name that we see most commonly used for dynaprostone is Cervidil. I'm going to show you what Cervidil looks like. It comes in a little tape. It's a little fabric tape. It looks kind of like Bi's tape or something. And the prostaglandin, the dynaprostone, is impregnated into the end of that. This is placed in the posterior fornix, which is kind of the space. There's a little pocket space right back behind the cervix. So this is placed behind the cervix. The dynaprostone is released gradually, and it can be used to soften the cervix. One of the benefits of that Cervidil is if they're having too strong contractions or too many contractions, or if the fetus is not responding well to those contractions, the Cervidil can be removed, and whatever hasn't already been absorbed is removed, so we can stop the action of that. There are a couple of other options. Prepidil is dynaprostone, so it's also a prostaglandin. It comes as a gel that's placed in the same location, the posterior fornix. Now, this gel is actually dosed to ripen the cervix. That gel can't be removed if they are hyperstimulated. So if they got too many contractions or they're too strong, we can't get the gel back. They may need to give a med to counteract that, or do some other things to counteract that, but it can cause too many contractions. Those methods are pretty expensive. So several years back, it was discovered that there is a medication used to prevent ulcers in patients taking NSAIDs for chronic disease called Cytotec. Okay, that's also the generic name is misoprostol. It is also a prostaglandin. So prostaglandins will induce contractions. So it was tried as an alternative because it's much less expensive. The thing with Cytotec or misoprostol is that it is not dosed for induction of labor. In fact, the manufacturer has put out warnings requesting it not be used for induction of labor because they're concerned about liability. And because it wasn't dosed for induction of labor, providers all had different dosing regimens that they used. It can be given either orally or can be placed in the posterior fornix. There are some providers who still use misoprostol for induction, Cytotec. They tend to use a lower dose now. When they first started using it, they were using sometimes 50 to 100 milligrams, which the tablet's 100. Now they're more likely to use a 25 milligram dose. But it has been associated with more frequent instances of overstimulation, and that's because it wasn't dosed for induction of labor. So you need to know what Cytotec is. You need to be aware of kind of the controversy surrounding it. It's still used in some places. There are some facilities that no longer allow it to be used in labor and delivery. Another method, that's prostaglandins, and prostaglandins can help ripen the cervix. The goal of cervical ripening is to get the cervix softened up and ready for induction. Okay, so there also are some other ways that we can ripen the cervix. There are some mechanical ways. I'm going to show you a picture of a balloon. And this balloon actually was created just specifically for cervical ripening. This is placed, the larger balloon is placed above the cervix, the smaller balloon is placed outside the cervix, and then the pressure of, the idea is that the pressure of that balloon is going to gradually stretch the cervix, thin it out some, and try to ripen the cervix and get it ready, soften it and get it ready for labor. A lot of providers were actually using, and still do, use Foley catheters for this. It just has one balloon instead of two. So that balloon, if it's a Foley catheter bulb, that balloon is placed and inflated past the cervix, and then the pressure tends to get the cervix to start ripening. It causes a lot of contractions and cramping. Either way, this causes lots of contractions and cramping. The major risk is infection. Typically, when the balloon falls out, they're close to 4 centimeters dilated, and the cervix is thinning and softening. So this is another option. Let's see. I'm going to stop share and reshare to make sure that you can see this. Another mechanical cervical ripening agent is Laminaria. This is also sometimes used to dilate the cervix for DNC or for abortion. Laminaria are these little, they look like sticks, and but they're made from a type of seaweed. When they're placed in the cervix, they absorb the fluids in that space. So they absorb just the fluid from the tissues that's being secreted, and they grow. And so they manually increase in size and manually dilate a little bit. And that it will start some contractions and cramping. It also will start ripening, softening that cervix. Another option for mechanical cervical ripening, if the provider can get enough space in the cervix, if the cervix is dilated enough to admit a finger, they may manually try to gently separate the membranes from around the edges of the cervix. It's called membrane stripping or amniotic stripping. It also causes a lot of cramping, but it can get things going as far as getting the cervix ripening, starting some low contractions. I've also seen low-dose Pitocin used as a cervical ripening agent. In that, when it's being used to induce labor, the dose of Pitocin is gradually increased over time to achieve a contraction pattern. If it's being used for ripening, it's all hooked up the same way. which we'll talk about how to hook that up in a bit, but it's all hooked up the same way. It's just administered at a very low dose, usually like a 1 millunit per minute, and it might be done overnight, causes some contractions through that time period, and sometimes will help soften and prepare the cervix to begin labor. Now, one of the things you need to know about cervical ripening is that sometimes, probably a good part of the time, not every time, but a good part of the time, those methods that are used to ripen the cervix will actually trigger labor. Like they will go on and begin labor after the cervical ripening has been done. There are some risks to cervical ripening. Tachysystole is too many contractions, too hard contractions, not enough break between them. So too close together, lasting too long, too hard. That's more common with prostaglandins, okay? Placental abruption is more common if we're trying to either ripen the cervix or trigger labor, and it's more common with prostaglandins. Amniotic fluid embolus, that's more common with prostaglandins. Uterine rupture is more common with prostaglandins. Those mechanical methods where we put something in the cervix to try to dilate it, those have a greater infection risk, okay? So we've talked about ripening the cervix. Now we're going to talk about methods of induction. This is when we are just going to try to get labor started. One of the most common methods of induction and kind of lowest intervention is breaking the water, amniotomy. Amniotomy should be done when the cervix is ripe. If the cervix is hard, if they have a low Bishop score, amniotomy starts the infection clock, and then they still may not go into active labor. So you've increased the infection risk. You're committed to deliver that patient, or the provider is committing that patient to deliver if they break their water. Amniotomy is artificial rupture of the membrane. So once they break water, they're committing to deliver, because after about 24 hours, the risk of infection gets a lot higher. There's also a risk when they break water of the cord washing out with the fluid or getting compressed without the cushion of that fluid. So they break water with usually one of two tools. There are a couple of other things that are less commonly used, but the one of two tools. An amni hook looks like a long flat crochet hook. Plastic long flat crochet hook. That hook is a little bit sharp. It's not gonna, the end is blunted, but the hook is gonna catch in the membranes and break that water, okay? So one of the other options for breaking water instead of the amni hook is the amni cot. And this is a finger cot, which is like a piece of a glove just for one finger. And it's roll down over that finger. You're going to have a sterile glove on that hand and then apply the amni cot. And it's just got a little hook or something to break the water. Okay. That's an amni cot. Those are the most common reasons or ways that you're going to see water broken. When membranes are ruptured, typically within an hour or so, labor starts to pick up. Okay. Amniotomy is usually more successful as an augmentation method than inducing with no previous contractions. It also is more likely to be successful if the person has already had babies before. If someone has never had a baby, not having any contractions, amniotomy is probably not a fantastic idea. Now, that's not our call. We're not the provider, but just so that you know, it's less likely to be successful if they're prima gravida, and it's less likely to be successful if they're not already having contractions. The most common method of induction in the US is going to be oxytocin. And this is when synthetic oxytocin, Pitocin, PIT, is administered IV to stimulate contractions. You have already learned how to do some Pitocin calculations. Usually, Pitocin is ordered in milliunits per minute, and the provider writes parameters for titration, but the nurse is responsible for assessing the patient and titrating that med based on the contraction pattern and the fetal and maternal responses. So the goal is to titrate that medication to get a good, strong contraction patterns, strong contractions every 2 or 3 minutes with enough rest between them but we want strong contractions every 2 or 3 minutes. We also want to make sure that those contractions are not causing a non-reassuring fetal heart pattern. So we're watching the fetal heart tracing, and that the contractions are not causing excessive pain or injury to the mother. The nurse may decrease or discontinue the oxytocin and restart it as indicated. The order will say start Pitocin at 1 millinunit per minute, increase by 1 millinunit per minute every 15 minutes to achieve whatever contraction pattern they want. So if we have to stop it for some reason, we can restart it. Now, if it's been stopped for more than, if it's been stopped for less than 20 or 30 minutes, so if we stop it, it's been 15 or 20 minutes, we want to restart at half the previous dose. So if we had it up to 6, we had to stop it, we're going to restart back at 3. Okay. If it's been stopped for more than 30 minutes, then we've got to start from the beginning and titrate upward again. Okay. So that titration, this is a nursing responsibility. We have parameters, but it's a nursing responsibility. Pitocin has to be run on a separate pump. So we have one pump for their regular fluids and we have one pump for their Pitocin. Pitocin needs to be connected to the port that is closest to the patient. It has a really short half-life. So if the patient has tachysystole, they have too many contractions, too close together, lasting too long, or the fetal heart rate is not responding well, and we have to turn off the Pitocin, we have less Pitocin in the line that's going to the patient if it's in the port closest to the patient. Okay. Fetal monitoring is required. It's recommended to begin with a low dose and go up in small increments. Some providers want to start with a higher dose and go up by larger increments. The problem is that it doesn't tend to work as well that way. So we want to, it's preferred to begin with a low dose and increase in small increments. There also are max doses, and the max dose is going to be set by the facility. And that max dose is based on safety. What are the risks of induction? Very similar to the risk of ripening, because we're using some of the same things. Uterine tachysystole, we get them hyperstimulated. Placental abruption, the placenta is separated from the wall of the uterus because the contractions are too hard. Uterine rupture because the contractions are too hard. Non-reassuring fetal heart patterns. Cesareans are more likely, both because of those risks associated with induction, but also because that patient just may not have been ready to deliver, or may not have been able to deliver. Maybe that's why they weren't in actual spontaneous labor. And there is a greater risk of postpartum hemorrhage if the patient has an induction. Okay, next section is going to be about AROM, not AARON, AROM, artificial rupture of membranes.